Hi, this is Alicia Bright. We're going to talk about part two of cancer. We're going to focus on nursing care this time. So we talked about surgical therapy, chemotherapy, and radiation therapy. Well, that's great. The doctors have tools in their arsenal that they can fight the cancer with. But in the meantime, nursing is focused on the patient who is undergoing treatment. So treatment is often uncomfortable. Some people make it through pretty lightly, but some people can have devastating effects. There's a whole range in between. So myelosuppression, you know that patients with cancer are often immune suppressed and susceptible to infection. They're often quite fatigued. That's in fact probably the number one complaint about cancer treatment is the amount of fatigue that people experience. They have GI problems, mucositis. The lining, the mucosa, the lining of the GI tract is quickly reproducing, and the chemotherapy and radiation therapy can affect those cells first. They'll slough. People will end up with sores in their mouth or digestive disturbance, and it can be pretty miserable. They can be anorexic. They can have dysgeusia. Everything tastes awful. They can lose their hair, alopecia. They can develop pulmonary problems, cardiac problems, and reproductive problems. So complications of cancer are also a problem. Of course, people can develop infection. Things like superior vena cava syndrome and spinal cord compression, these happen when the tumor grows and pushes against vital organs, including the spinal cord. And that's one of the reasons that we'll do surgery to debulk those tumors, relieve pressure on vital organs. Third space syndrome, when people retain fluids and swell. Tumor lysis syndrome. Tumor lysis, if the tumor is lysing or dying, breaking down, that's good news. But the body then has to deal with the effects of the breakdown, with the tumor byproducts, the byproducts of cellular breakdown. And it has to engage in phagocytosis and move the debris out of the body, and that can place a great strain on the body. It can make somebody awfully sick. SIADH is syndrome of inappropriate antidiuretic hormone. So if you've got inappropriate levels of antidiuretic hormone, you're going to be retaining fluid. Hypercalcemia can happen, particularly with bone tumors. It can move calcium out of the bone and into the blood. A little refresher on fluids and electrolytes there. So late effects of radiation chemotherapy can be devastating also. People can have cognitive changes. My father had radiation and chemotherapy for colon cancer and then also for sinus cancer. And he ended up on the couch for 6 months, roughly 6 months, while he regained his energy and his ability to focus. They hadn't told him about chemobrain. Chemobrain is the decreased cognitive efficiency, slowness, fogginess that happens after chemotherapy. And it can be quite devastating. It can be permanent, it can be progressive, but it can also go away. My father did actually recover from that and was able to go back to functioning pretty well for a while. People can also develop secondary cancers, and of course, cancer therapy has psychosocial effects on people. It affects their own self-image, their body image. It affects their relationships with other people. Some complications include, as we said, physiological alteration of taste. We don't know why that happens, but we can work with people to find foods that they like and avoid foods they don't like. Experiment to create different flavors. A lot of times people just like a bland diet without a lot of seasoning, something easy to digest. It can easily result in malnutrition, and cancer is, it's often noted that cancer patients will lose weight. They have fat and muscle depletion. And if they've lost more than 5%, they should definitely have a dietitian consult with them. So cachexia is the term for wasting that can happen with cancer patients. It can happen with other people too, most notably COPD patients. But anorexia can cause this cachexia. It involves skeletal muscle atrophy and immune dysfunction and metabolic abnormalities. So a lot of factors influence coping, and coping is a Giddens concept that factors in quite a bit for cancer patients. Demographics. If you have financial resources, having cancer is a very different experience than if you don't. How old are you? That makes a difference. What kind of social support do you have? What kind of prior life experience do you have that's informed your ability to cope and your strategies for coping with crisis? What kind of social support do you have? Having people in your life makes a huge difference. And what's your spiritual and religious beliefs about health and illness? For instance, people who feel that they developed cancer because they did something wrong and they're being punished, that would definitely have a heavy psychological impact on somebody, as opposed to someone for whom cancer was just sheer bad luck. But at any rate, we need to assess people very carefully. You get to know them a bit so that you have a sense of how they cope or not. And you can find out about their fears and their hopes. We want to foster hope in cancer patients, but they're going to be afraid of dependency. They're going to be afraid of loss of control, which is their bodies are doing something that's disturbing. Family relationships are involved. As I said, people with the financial resources to take care of themselves are going to have a completely different way of approaching this than people without financial resources. Fear of death factors into this. But you should know that cancer is not the death sentence that it once was. We can treat cancer. We have ways of treating it medically and supporting the person undergoing the cancer treatment, so that many times it is curable or at least controllable. Not always, but it's not the death sentence that it used to be. And as a nurse, you're in a position to really support somebody's ability to cope. So how do we support people's ability to cope? Well, the first thing we need to do is to build a trusting relationship with somebody, establish rapport. We do this by being reliable, by providing symptom relief, by following through on our commitments that we make to them. We can use touch in a respectful and gentle way that establishes trust. We can help the patient set realistic goals. It's fascinating to me to read studies, as I have, that talk about the death rate for people who have chronic illness decreasing before major holidays and then increasing afterwards. So there's something about the human spirit that can hang on in order to reach a particular goal. Somebody who just wants to stay alive long enough to see that great-grandchild born, that person just might be able to do it. Not all the time, but we need to help people figure out what they want to accomplish and what their hopes and goals are, and we want to try and help them to be realistic and then to meet those goals. Maintaining hope is vital for a cancer patient. We need to help keep their spirits up. Exhibiting caring behavior is vital. Making yourself available, listen actively, ask questions, and provide accurate information. Don't forget the family. We need to care for the caregiver. We need to care for the people who are caring for the patient with education, support, maybe psychosocial interventions, give them information about resources. For instance, there's a summer camp, Camp Oziku, for children with cancer. And they also have a summer camp, I believe, for siblings of patients with cancer. So there are different programs in place to support the caregivers for these folks. So make that information available to people. By the way, if you ever want a summer job, that Camp Okizu is awfully fun. They recruit from Dominican every year. So keep that in mind. Often during the junior and senior year is a good time to go and do that. So it's really important to give holistic care to a cancer patient. Once again, with this condition, each person is going to have their unique path through this crisis. And it is a crisis at first, at least, and it can go on for quite a while. So each person is going to have their own experience. We attend to the individual and the individual's experience and take each problem as it comes and problem solve with them. Cancer patients were, years ago, became very frustrated with treatment because it is a chronic disease, and they started looking for complementary and alternative ways to approach cancer care, and actually made the complementary and alternative health movement a thing. Right? They helped put it on the map. So that's why I include integrative health practices in this program, because a lot of cancer patients do avail themselves of these things, and anymore, a lot of folks avail ourselves of these things, especially in the Bay Area. So we will talk about that in our next lecture.